Hey, good afternoon, everyone. Welcome to this afternoon's deep dive discussion. Our topic will be platelet transfusion refractoriness and a case-based panel discussion. I'll be chairing. Those who don't know me, I'm Jacques Malherbe, the head of clinical hematology at the University of the Free State. We're going to have presentation and discussion by Dr. Caroline Steyn, Prof. Matthew Seftel, Dr. Akash Gupta, and Dr. Johnathan Mack. Bridget, can you advance? Oh, wait, I'm trying to advance this. So just some housekeeping notes. A reminder that recordings can be found on the bloodsa.org.za website under resources and deep dive. Please feel free to type any comments or questions in the chat box. There will also be an opportunity to, at the end with the discussion, to unmute and ask questions in person. If you want to be added to the mailing list, please email Melanie, melanie.davids@uct.ac.za. The meeting is CPD accredited and it is CPD points are automatically submitted to the HPCSA. If there's any queries, you can also contact Melanie about that. And 1 hour attendance is needed for the CPD point. Blood SA and the speakers, we really value your feedback. So please provide the anonymous feedback at the end of the session. So just to thank the management team of Blood SA, Estelle, Prof. Berg, Gardine, Bridget, Nicolai, and Melanie. They're really running a very smooth ship. So our agenda today, we're going to have 2 case presentations, one of our patients that will be presented by Dr. Steyn, Dr. Caroline Steyn, and then the second presentation by the team from Canada. And then we will have a short talk on platelet transfusion refractoriness, followed by a panel discussion. And then just to note, next week's topic will be bispecific antibodies, redefining relapse refractory treatment in follicular lymphoma. So just to introduce our speakers, Dr. Caroline Steyn is my colleague and a right-hand woman. She is a very important part of our team here. She's a specialist physician and clinical hematologist at Universitas Academic Hospital here in Bloemfontein. As an affiliated lecturer here in the University of Free State, she's intimately involved in training students and registrars in internal medicine and hematopathology, and she's got an interest in patient blood management. Prof. Matthew Seftel, I think most of us know him very well. He's a clinical hematologist at the Canadian Blood Services, and he serves as medical director for the Canadian Blood Services Unrelated Donor Stem Cell Registry and Cord Blood Bank. He's a clinical professor at the University of British Columbia in Canada and an honorary professor at the University of Cape Town, South Africa. His academic focus include clinical outcomes in hematological malignancies, transplant, and cellular therapy. He's current president of the World Marrow Donor Association. So welcome, Matthew, and thanks for being here. Then Dr. Akash Gupta, he's the medical director of the Canadian Blood Services National Platelet Immunohematology Reference Lab and a transfusion medicine specialist at Sunnybrook Health Sciences Center. He also supports the CBS National Immunohematology Reference Lab and the Rare Blood Program with medical services. Thanks, Akash, for being here, and I assume it's the young Gupta who's also joining on the talk. Then Dr. Johnathan Mack is a consulting hematologist at McGill University Health Centre and a medical officer with the Canadian Blood Services, where he's involved with HLA and HBA selected platelet program, the Rare Blood Program, and the National Immunohematology Reference Lab, and the Leukoreduced Whole Blood Program. So with that, I've introduced our speakers. And I'm going to hand over to Caroline to start off with a case that I think you'll find interesting. And so Caroline, I think Bridget, you can, yeah, great. You can...
All right, sorry everyone. Thanks so much for the introduction and for the opportunity to present a case to you today. I'm going to switch off my video and just keep the audio on. So just in the interest of time, I'm going to try and go through this case as quickly as possible, although this is a really fascinating and complex patient. So I'll just endeavor to keep it to the main point. So my talk is titled "Where Have All the Platelets Gone?" and this is clinical case 1, and yeah, this is our patient. So our patient is Miss Katie. She was initially actually a consultation to clinical hematology from the obstetric service in mid-July of this year. She's a 30-year-old lady, graft 2 para-0, presenting at basically a term pregnancy, 37 weeks, almost 38 weeks gestation. She had a history of a previous first trimester miscarriage, and she had presented about 5 days prior to the consultation with overt macroscopic hematuria and petechia on her abdomen and thighs, and at this point was actually found to be pancytopenic. Severe thrombocytopenia of 5 times 10 to the 9 per liter, severe anemia of 6 grams per deciliter, and initially something I think we possibly overlooked slightly, but she was neutropenic as well. Not really severely neutropenic up front, but you know, her subsequent values were all in the below 1 range, so she had moderate neutropenia as well. This patient had her main pertinent history was that she'd had, interestingly, some easy bruising for about 2 years prior to presentation, and then this kind of equivocal history of gum bleeding when brushing her teeth of a more recent onset. Her past medical history was only significant for the fact that she was morbidly obese and noted to be hypertensive when she arrived in the obstetric unit. But she had also no surgical procedural history. Her obstetric history was only that of that first trimester miscarriage that was obtained in 2021. Unfortunately, there wasn't much extra information about this, and the patient didn't have, at this point, any clinical features of antiphospholipid syndrome, but it was still, you know, sort of in the back of our minds. Her current pregnancy was essentially unplanned, but an accepted pregnancy. It was booked at about 22 weeks gestation. And on her prior antenatal visits, she had a record in her antenatal booking chart that she was anemic and was managed sort of empirically with oral iron supplementation at that point. She had no real social history of note, no use of sort of over-the-counter meds either, no herbs or tonic water use. And then just of interest, and I'd be interested to know if anyone has any opinions about this. We don't have a clear etiological link, but we found out that her first cousin, her paternal first cousin, is actually a known patient to us at Universitas Hematology. She presented in 2022, the cousin with severe aplastic anemia, and received ATGAM and cyclosporin, and this patient at present is in a complete remission. So just a very interesting kind of fact. On initial clinical examination, this patient was found to be obese. She was well orientated and alert up front. She was pale but not jaundiced and had no enlarged lymph nodes or detectable splenomegaly, although with the BMI it was a little bit difficult to ascertain. She had essentially widespread ecchymoses, mainly where blood had been taken. She had marked widespread petechia on her abdomen, and there were no oral hemorrhagic bullae noted at this point, and there's this very overt macroscopic hematuria. So our first thought, initially was this ITP in pregnancy, severe thrombocytopenia and anemia. She was kind of, because of the concern about how close she was to term, she was given Polygam and a steroid pulse while we were pursuing further workup. Also empirically was given IV iron replacement, as well as folate and B12 supplementation. And after about a week to 10 days, it was noted pertinently that there was no response to these measures. The patient also had been transfused multiply with both blood and platelets, actually almost daily at this point, with no platelet increments, and I'll show you her flow chart in a minute. And her, obviously the penny started to drop here that we should check her platelet recovery. So this was done formally on 2 occasions with a 1 hour post-transfusion platelet value of less than 10 on, well, actually on all occasions. We checked it formally twice, but you'll appreciate that her platelets hardly ever went above 10. So at this point, we came to the conclusion that she was most likely platelet refractory. And our first thought there is this immune or non-immune. So just as a reminder to all of us and to the trainees, this is a common question in exams. What are the causes of non-immune platelet refractoriness? And we all know sort of the common culprits here are fever, sepsis, infection, splenomegaly, and DRC. Obviously, diagnosed or undiagnosed bleeding, as well as a number of medications. Obviously, this patient wasn't post-transplant, but then the other side of the coin is this immune-mediated platelet refractoriness, in which case we would be looking for anti-HLA and anti-HPA antibodies. So just again to re-emphasize, not to go through this entire flow chart, but just to kind of have a look at the platelet trend on this initial point of contact with these very, very low values. And then just to highlight, for the sake of time, the important results that were found in this patient was that she was HIV negative, or she is HIV negative. Viral hepatitis B and C were excluded. Her autoimmune workup was essentially negative with no antiphospholipid antibodies either. She was B12 and folate replete, obviously after supplementation, but the supplementation didn't also alter the course of this patient. She was not in DRC, and she at this point there were no septic foci identified. She had a ferritin of 1,000. This was post-Cosmifer, just to note. Normal complement levels, and her liver enzymes were also normal. So we weren't really thinking along the lines of HELLP syndrome at this point. Normal thyroid function and normal haptoglobin. So we didn't really have any indication that there was a non-immune cause for this patient's platelet refractoriness now. Then we got the bone marrow back. So this patient did have, because of the actual diagnosis of pancytopenia, she had a bone marrow. And although it was a technically challenging procedure, one can appreciate the very marked hypercellularity on this section, mainly fat spaces with very minimal preserved hematopoietic elements. So really just pointing towards a diagnosis of aplastic anemia. So our initial problem list was that this patient now had aplastic anemia, mainly manifesting with this very severe thrombocytopenia and bleeding. She, just of note, didn't have a PNH clone present, and there was no clear secondary cause at this point. There was a bit of a question about the symptom onset prior to pregnancy, because she certainly had, we had to kind of really dig into the history, but that slight bleeding history prior, and the fact that she'd had a blood transfusion prior to pregnancy, could this still be pregnancy-associated aplastic anemia? It was difficult to say up front, but the subsequent course has the fact that the patient is still that she did not recover post-delivery. I'll get to that a little bit later. So we thought at this point that idiopathic aplastic anemia seemed most likely, but we also considered other or competing or complementary diagnoses, such as post-transfusion purpura or even transfusion-associated graft-versus-host disease. The patient did not show any of the typical features of TA-GVHD and, is still alive today, so that was clearly not the cause. But we made the conclusion that she was indeed, did have alloimmune platelet refractoriness because of the presence of high-level multi-specific antibodies against HLA class 1, and there were no HPA antibodies present on 2 occasions. And then, of course, this imminent delivery, which was causing everybody sleepless nights. So on feedback from tissue immunology, we found firstly that the patient's auto cross-match results were negative, so she did not have any auto antibodies to her platelets. And the HLA type, or the HLA antibody testing revealed that she had multi-specific high mean fluorescent intensity antibodies, as you can see on the graphic on the right, or the table on the right side, and she will definitely require HLA matched platelets. So I'm not going to comment too much on the actual details and intricacies of these antibodies. I think we can just note that the intensity was noted to be 19%, and I think I'll leave the experts to comment on that. Just again, her HbA testing in July at this presentation was negative. So again, just to kind of re-emphasize that we, at this point, excluded post-transfusion purpura, and she had the proven hypercellular bone marrow. So it was felt that that was not the case, as you can also see on the result, serum screen for IgG antibodies to these platelet glycoproteins. Again, the same testing, just to jumping forward a few months in October, it was repeated with similar results. Again, HbA testing was also negative, and there was positive serum screen for IgG HLA class 1 antibodies. So, I mean, this is just to really talk about this case. We had many things to consider with this patient. Firstly, we had to try and address the aplastic anemia in pregnancy. So we started her initially on cyclosporin. There was unfortunately no ATGAM available at this point due to no stock. We submitted an H101 for Altrombopag, and actually received a month of Altrombopag stock post-delivery. She did eventually get ATGAM, but this was about a month after, she received ATGAM in August. So we also, sorry for the typo, wanted to address obviously the fact that she had platelets or alloimmune platelet refractoriness. So in an attempt to expedite a safe delivery, we kind of threw the kitchen sink at her, in the sense that we were thinking, you know, if we can reduce the antibody intensity and the antibody load, then this, you know, it may assist us to deliver this baby in a safe manner, where she would not, or maybe would respond to, you know, to normal platelets. And at the same time, we also instituted an urgent search for HLA matched platelets. So she had rituximab. I think she got 3 doses of Ritux. She was plasma exchanged 4 times pre-delivery, basically in the week or so pre-delivery. And as I said, we instituted an urgent search for HLA matched platelets. And she had 5 siblings that were all called in for HLA, HbA typing, and unfortunately, none of them none of them were a match. And then, of course, we wanted to address the delivery of this baby. So we had a lot of thoughts about the delivery method and who should attend this birth. Just a quick sort of sentence about the baby. We got the neonatologist involved and thought that, you know, some interventions would be cord platelet count prior to any interventions on the baby, as well as the consideration about B cell depletion, and the baby's immunization schedule, seeing as the mom had rituximab. And then Matt also just, you know, highlighted that we should consider fetal and neonatal allo immunization, alloimmune thrombocytopenia, but the baby had no complications peri-delivery and is clinically still well and has had no bleeding. So that was probably not the case. Then just as, not to go through this in extreme detail, but we really just kind of gave a lot of thought to this birth plan, and sort of drew up a stepwise approach that the obstetricians should follow, you know, prior to active labor, at the onset of labor, or prior to C-section, basically whichever method was going to be the best for the mother and the fetus, and then during delivery as well as post-delivery. And this was basically just, you know, trying to consider all aspects of hemostasis. Firstly, trying to, you know, reduce the antibody load, as I've alluded to, avoiding kind of neuroaxial anesthesia as far as possible, and then, you know, what we were going to do about platelets. So we tried to get, as I said, we were trying to get HLA matched platelets, but actually they did not arrive in time for the delivery. So this patient had non-matched platelets and actually did really well. And then we just also thought about, you know, monitoring her other coagulation parameters to optimize hemostasis, as I've mentioned. So an HLA matched donor was actually identified by the SANBS on the 5th of August, which was just fractionally too late for delivery. So the patient on a weekend developed fetal distress, had an emergency C-section on a Saturday night, on the 6th of August, I think. And yeah, the good outcome was that there was very minimal intra and postpartum bleeding, and she successfully delivered a live fetus. And we emailed the tissue immunology lab back about the fact that this patient had delivered her baby. So we actually deferred the ordering of the HLA matched platelets at this point because she wasn't bleeding. And then we sort of, again, checked whether any of the siblings were a potential HLA match, because first, preferred therapy for severoplastic anemia is obviously a matched sibling transplant. And unfortunately, none of her sibs were HLA matched. So just to end off, the long road since then is that this patient did eventually receive her ATGAM, as I said, in August. She continued the cyclosporin, and we did manage to procure a month of eltrombopag. We transfused HLA matched platelets because by this point we had identified 2 available donors, and this was just done basically for procedures per availability. Otherwise, we transfused non-matched platelets if it was needed for surgery and procedures. And what I mean by that is, unfortunately, this patient has had a very complicated course with a lot of wounds and abdominal complications necessitating relook laparotomies. And I'm not going to go into that now, but where needed, we actually managed to give her non-matched platelets, and she's had relatively good hemostasis, although she now has also had, we think she's had multiple intra-abdominal hematomas. So this is causing a lot of morbidity at the moment. Anyway, we also just instituted a lot of supportive measures, as I've alluded to. And this patient has had a very complicated course, which I can talk about if it's relevant. So in summary, this patient had sort of a perfect storm of aplastic anemia occurring in pregnancy with platelet refractoriness and multiple subsequent complications, mainly related to actually her cesarean section and infectious and bleeding complications intra-abdominally since then. I think just to highlight the challenges relating to the diagnosis and subsequent management of alloimmune platelet refractoriness, and really, just as a reminder about these different causes of non-immune versus immune-mediated platelet refractoriness, and the fact that actually obviously both can occur in the same patient, but one should try and, as far as possible, sort these out whilst managing. Okay, I'm sorry, I've actually gone over time. That is my story.
Thank you, Caroline. So Jacques, is it okay if I proceed to share my slides now?
Please go ahead, Matthew. That's perfect.
Okay, if you just give me a sec while I share my own screen. Thank you very much for that pretty startling case, Caroline. A reminder about how complicated things can get very rapidly. And I think the important thing about your case, in addition to those that you already highlighted, was that when we are caring for patients with complex hematologic issues, it's easy to overlook the fact that we are dealing with other specialties involved in the care of that patient, and they come from various sources. You mentioned obstetrics and gynecology, and there's interventional radiology, there's other surgical specialties, etc. There's many others. And so ensuring that those caregivers and those specialties share the same plan as you is very important. So the simple act of good communication and discussion is sometimes vital, and I might say even life-saving for patients. And that's particularly with urgent surgical procedures like the one that you summarized. So that's a nice case to start this discussion. So I'll start our part of it just to let you know that none of these 3 speakers, myself, Dr. Mack, or Dr. Gupta, have any disclosures for this presentation. So just to move on from Caroline's talk, we'll have 2 objectives. One is to review Canadian practice regarding platelet transfusions. I think that might be nice for you to understand how things are done in this jurisdiction, with some ability to compare and contrast to how transfusions are provided and sourced and provided in your South African setting. And then, of course, we'll touch on diagnosis and management of platelet refractoriness, and we'll give you another brief case at that time. But I really think it's important that we have room for entertaining discussions from the listeners. So I'll be brief. So just as a very broad introduction to transfusion medicine in Canada, we have two major blood manufacturers. So around for approximately the last 25 years, there are two major suppliers of blood. One is Canadian Blood Services, with which I'm affiliated, as well as Dr. Mack and Gupta. And we serve the majority of the country, from west to east and to the north as well, with the exception of the province of Quebec, which has an independent blood manufacturer. So their donors are sourced locally from the province of Quebec, and they have a separate administrative and blood manufacturing and provision and distribution system. So I'm aware that there are some commonalities there in the South African system, where you have Sanbis, as well as the Western Cape Blood Supply. So perhaps you'll be familiar with that structure. Very different to the US structure, where multiple collection centers and multiple manufacturers and distributors exist for blood. So with respect to platelets, I won't go through this slide in great detail, but just to let you know that for approximately the last 18 months, all platelets that are supplied by Canadian Blood Services are subjected to a pathogen reduction system, such that whether that relates to buffy coat platelets, which represent the majority of platelets that we manufacture and provide for patients, which are pooled, as well as to apheresis platelets, which represents the minority of platelets. These are universally leukoreduced and, for the last years, subjected to a pathogen reduction system using the intercept system, whereby we introduce a Sorolin photosensitizer, and pooled platelets are subjected to ultraviolet illumination. And at that point, distributed to sites to be issued to patients. The advantage of the pathogen reduction system, and the primary reason for it, is to remove and effectively pathogen reduce all products. And by removal, it will be any DNA or RNA containing pathogen. So that would include bacteria, which is traditionally the biggest concern with platelets that are collected and stored at room temperature, as well as no need for irradiation of platelets. So that is the majority of platelets, pooled buffy coat system. And a similar system for single donor apheresis platelet, which represent the minority of platelets that are issued to patients. But some of those, of course, would be HLA or HPA selected. Just to give you some ideas of the numbers that are being transfused in Canada, this is a pretty large number of platelets. As you might expect, the majority of recipients of platelets would be for those with bone marrow failure states, including those being treated for hematological malignancies and stem cell transplant. But of course, there are surgical and other indications as well. So in the red are units of pooled platelets issued in that last calendar year available, last financial year available up to 2023. Just under 100,000 pooled units were distributed. And then apheresis units around 26,000. And a much smaller number, but still substantial number, of HLA or HPA selected units, 4,270 or so. So it's quite a substantial outfit to ensure that these units are manufactured well and distributed across a very, very large geographic area. So when it comes to the types of patients that you guys are seeing, which is complex hematology, and the example that Carolyn gave was a very complicated hematology patient. And of course, complex hematological malignancy like the acute leukemias and transplant. I think there are peculiar risks for these sorts of patients. And I've listed them here. I think you will probably know about all of these risks: iron overload, the complexities of ABO incompatibility with transplantation, the risks of hepatic sinusoidal obstruction syndrome that are associated with red blood cell transfusion in transplant recipients. And then the one that, of course, I've circled, which we'll discuss in greater detail now, which is platelet refractoriness. But don't forget there's others: the importance of transfusion-associated graft versus host disease in immunosuppressed patients, and with that immunosuppression, a greater likelihood of transfusion-transmitted infection. So refractoriness is just one of the topics to highlight. So I'm going to move over to the next speakers. This is Dr. Johnny Mack to discuss case number 2. And now, Johnny, I'm going to try to give you remote access. There we go. Okay, Johnny, you should be able to move the slides independently now.
Perfect. Thank you very much, Dr. Seftel and Dr. Steyn. And just going to give a test click here to make sure that I do indeed have control. Yes, things work good. So good afternoon. We wanted to present or move on to the next session, presenting a brief case, nothing nearly as complicated as Dr. Steyn's case, but something just to anchor some of the discussion around how we approach management of a platelet refractory patient in the Canadian blood system, at least on the Canadian Blood Services side. So this was a case that we had of a 4-year-old patient with acute myeloid leukemia, who had thrombocytopenia, not surprisingly, and complicated by active mucosal bleeding, quite a bit of epistaxis, as well as gum bleeding. It was quite distressing to the family and the patient, and was requiring quite a bit of transfusion support. And the treating team noticed that despite transfusions of up to 3 pooled random donor platelet units a day, they weren't getting any increment in the platelet count. And so they then moved on to appropriately confirm with a 10 to 60 minute post-transfusion count that indeed the platelet count wasn't increasing with the transfusions, which led them to reach out to Canadian Blood Services for some additional assistance. So other non-immune causes of platelet refractoriness had been investigated and ruled out in this particular patient. So it seemed like a really, very compelling case for an immune-mediated platelet refractoriness. So that brings us to the question of, well, what is platelet transfusion refractoriness? And there's a few different definitions that you'll come across in the literature. On the bottom of the slide here is the most formal definition, which if you have the information available to calculate the CCI, or the corrected count increment, is really probably the best way of defining platelet refractoriness. The benefits of using the CCI, which is this calculation on the bottom where you take the delta between the pre and post transfusion counts multiplied by the patient's body surface area and then divided by the dose of platelets that were actually transfused, is you can take into account the patient's body size, which obviously plays a role in how much of an increment will be observed in the platelet count following a transfusion. And if a poor CCI of 5,000 to 7,500 is observed after 2 consecutive transfusions, that is kind of used as a definition of platelet transfusion refractoriness. Now, we obviously don't often have the platelet count information from the actual transfused unit, so we're often using a bit of a rule of thumb ballpark approach. And for most patients, if we're seeing an increment lower than 20, sort of in the 5 to 10 range following a platelet transfusion, and that would be 1 dose of platelets, whether it's pediatric or adult patients, that generally leads to a CCI in this range of 5,000 to 7,500, and would be then consistent with platelet transfusion refractoriness. So key things here is not seeing an effective increase in the platelet count and seeing it on multiple occasions. Just a bit of an interlude here in terms of a question is, what is the most common cause of immune platelet transfusion refractoriness? with options being hypersplenism, HLA antibodies, HPA antibodies, or immune thrombocytopenia. Get people thinking about that, and we'll come back to this slide in just a second. So to carry on the discussion, I don't want to go through this in too much detail because Dr. Steyn covered this already, but in terms of the causes of platelet refractoriness that we observe when we do see the poor increments, there are the non-immune causes that need to be thought about, which include fever, infection, or sepsis, which can lead to an increased consumption of platelets. Bleeding, particularly if associated with a lot of additional co-transfusions of plasma and red blood cells, which can lead to dilution. Accelerated platelet consumption in conditions like DIC or microangiopathic hemolytic anemia or other thrombotic microangiopathies. Several drugs that have been implicated with increased platelet consumption, including amphotericin, vancomycin, ATG, some medications that we often see in the complex hematology post-transplant patient population. And then splenic sequestration, which can be seen in situations of hypersplenism, which can occur even in the absence of splenomegaly, so really just increased splenic function. And of these non-immune causes, just to get back to the importance of the 10 to 60-minute post-transfusion CBC, so in my experience, most of these non-immune causes will not lead to a poor increment immediately following transfusion. So you can get fooled into thinking a patient might have platelet refractoriness if we're looking at just the morning CBC and looking at the morning count. They get transfused later that afternoon, and then you repeat the CBC the next day. They may not increment, but if we do a CBC in that 10 to 60-minute window, we see they actually do increment, and then there's a slow decline or a gradual decline over the next 24 hours. And the first four causes here of apparent platelet refractoriness generally don't cause that rapid destruction, but splenic sequestration often can. So of the non-immune causes, that's the one where we often see a poor increment fairly shortly after transfusion. Of the immune causes, HLA and HP antibodies were already mentioned as important immune causes. So these are antibodies against antigens that are found on the platelet surface. There are a few other immune causes to consider. Not everything is in the HLA or HPA systems. Platelets do express ABO or AB substance. And so if a patient is receiving non-ABO compatible platelets, they may have anti-A or anti-B antibodies that could cause clearance of those platelets. There's also antibodies against drug platelet glycoprotein complexes that can form sort of like a drug-induced ITP. And also storage conditions of platelets can lead to clearance in the immune system of old or poorly stored platelets that may have undergone some membrane changes associated with that, which can then lead to some increased clearance. So a relatively broad differential to go through, but most of it's apparent from the history of the patient and some of the transfusion details. So returning to our question, what's the most common cause of platelet transfusion refractoriness? We suggest HLA antibodies are the most common cause of true immune platelet refractoriness. We do see HP antibodies, but much less frequently. And although ITP is a cause of immune platelet refractoriness, platelet transfusions are often not given as routine treatment of ITP, and so not as common a cause of the platelet refractoriness that we see. And hypersplenism, as we covered, is not an immune mechanism; it's a non-immune mechanism of platelet refractoriness. So just a note on the mechanism, this most common HLA antibody alloimmunization, which causes refractoriness. There are some important things about the manufacturing of the products that we observe that can influence the development of HLA refractoriness itself. So to develop HLA-mediated platelet refractoriness, the patient needs to have HLA antibodies. And two of the processing steps that Dr. Seftel had discussed that are in existence in Canada, universal leukoreduction of blood products and the recent introduction of pathogen reduction, are believed to have an influence on the development of HLA antibodies. We have relatively robust data suggesting that leukodepletion of blood products decreases the risk of HLA antibody formation, which makes a lot of intuitive sense that if you remove the white blood cell mass that's in the transfused product, that removes a stimulus for HLA sensitization and then less HLA immunization for a patient that's going to subsequently receive a platelet transfusion. And pathogen reduction, there's question mark because the data is a little bit less robust. It's a newer intervention on processing modification that's done with platelet production, but a meta-analysis, which will show the data from, suggesting that there may be an increase in immune-mediated platelet refractoriness. Sorry, I should say in platelet refractoriness. Whether or not it's immune, I think, is a question mark in pathogen-reduced platelets. So if we look at some of the data supporting this, Dr. Seftel is credited with this analysis of the Canadian landscape following the introduction of universal leukoreduction of platelet products or all blood products in Canada. And they observed in this study that when they compared the pre and post leukoreduction eras, HLA alloimmune refractoriness decreased from 14% in the pre-leukoreduction era to 4% in the post-leukoreduction era in Canada. Which again makes intuitive sense with the reduction in the HLA burden that's in the transfused products. And this is the meta-analysis I alluded to, where they looked at studies evaluating platelet responses in pathogen-reduced platelets. So a number of studies that looked at this, and the overall odds ratio for developing platelet refractoriness following transfusion of a pathogen-reduced product was increased at 1.61. What isn't known in these studies is the exact mechanism of that, whether this is truly HLA-mediated or if the actual pathogen reduction steps somehow modifies the platelet or increases the susceptibility of that platelet to be cleared in a non-immune way. But a fairly consistent finding across studies that pathogen reduction leads to a reduced increment in platelets following transfusion.
Important for me, not for you.
So moving on to some more patient-specific factors, and back to our case of this 4-year-old who's showing some immune platelet or some suspected immune platelet refractoriness. How do we confirm that? What do we do to actually diagnose platelet refractoriness? So there's 2 important tests that can be done, and we suggest doing this in a stepwise fashion, given the frequency that we see between HLA antibodies and HPA antibodies, with HPA antibodies being much less common. But the 2 tests would be screening for those antibodies. There's a test that exists to screen for HLA antibodies and tests that exist to screen for HPA antibodies. As Dr. Steyn had presented in her case, the initial screen being done for HLA antibodies. So this is an example of the output from the testing that would be done from an HLA antibody screen. In our centers, or in our system, this is done using the Luminex assay, which most of the audience is probably familiar with, but just as a quick review, the assay is a flow cytometry-based assay with individual beads being coated with different HLA antigen types. And each of those beads is then passed through a flow cytometer after being incubated with the patient's plasma. And if the patient has HLA antibodies that recognize the antigen on any given bead, the flow cytometer will then pick up the presence of that antibody. And the output here is seen in this report, where each individual column on this graph is representing an individual bead with a different HLA type or HLA antigen on it. And the height of the column here is the amount of antibody that is being picked up from the patient coating that particular bead. So in this particular example, we're seeing a lot of red here, which is showing us that each individual bead is being coated with quite a bit of antibody and giving a lot of signal. So this would be a patient who has quite a bit of different HLA antibodies recognizing different HLA types. And it's quite, there's a lot of interpretation that goes into this. There's cross-reactivity between different HLA groups, so we can't necessarily make a direct correlation of one individual antigen being an individual antibody specificity. But thankfully, the HLA experts that are out there can digest this and turn this into a readout, which was done for our patients. And the ultimate readout was showing us that this patient had quite a few different HLA class A and class B antibody specificities. And in isolation, that information can be helpful because we can then take those specificities back to our blood manufacturers and say, well, we want to have platelets that are not containing any of these antigens. Or the alternative approach, which we like to have as complementary information, is sorry to scroll around here, is the HLA typing of the patient, where we then can identify, well, what is the patient's HLA type? And rather than trying to go through our donors and find donors who don't have specific antigens, we can be much more directed and say, well, we want to find a particular donor who's an HLA match for that patient. But in order to do that, we have to be able to find the HLA type of the patient that we're interested in supporting in that fashion. And that's done using PCR-based amplification of their DNA to get their actual HLA genotyping. So that was done in our patient, and we identified the HLA type to be A24, A32, B27, B37. So now with the combination of these two tests, we're in a good position to be able to support them either through an antigen matching or an antigen avoidance type strategy. What we do with that information in our system is we'll take and plug the antibody specificities into what's called a CPRA calculator, which is important to highlight is a region and geographic based or has regional and geographic based variability. So using a Canadian CPRA calculator doesn't necessarily make a lot of sense in the South African context. And the reason for that is that the HLA antibody specificities that are seen by a particular in a particular potential recipient, they really kind of matter most in the context of where the donors are coming from. So, for example, in this particular case, when we looked at the different HLA specificities that we observed on our HLA testing, the CPRA calculator gives us this number, which is the PRA, and that tells us what proportion of the donor population the patient is expected to have antibodies against. And in our case, it's not very positive news. 99.93% of the donor population in Canada, this patient would have antibodies against. So it'd be very challenging to find a compatible donor if we're just randomly selecting platelets. Less than 1 in 100 platelets randomly selected would be expected to be compatible and to be able to evade that the immune response from these HLA antibodies. If we were to plug the same antibody specificities into a different donor registry, we might not get the same number. It really depends on what the HLA representation in the donor population is. And so that calculated CPRA has to be interpreted in the context of your donor population. It also is important to emphasize that the majority of the CPRA calculators are based on organ donor registries and not necessarily blood donor registries. And so they may not reflect what our blood donor population is. But a lot of centers we don't have that level of information for our blood donor populations. And so we have to sort of extrapolate from that organ donor population. But so our approach in Canada then is to plug that into the CPRA. And if we find our CPRA is relatively low, under 25 to 30%, we actually are quite content to support the patient with just random platelets, because one in every 3 platelets might be susceptible to immune clearance, but 2 out of every 3 will actually be just fine. And so when we think about the amount of effort that goes into trying to find an HLA compatible donor, contacting that donor, bringing them in, and the machinery that goes into that, it's just as easy to actually just use a random pool donor. But when the CPRA starts getting into the 30 to 50% range and higher, you're starting to talk about platelets, random platelets, not being effective 1 out of every other attempt. And so it starts to now become worthwhile going through the logistic challenges of finding donors who are HLA compatible. So that's our approach. We're fortunate to have a relatively robust HLA tested donor population. So we recently looked at our internal data, and we have approximately 11,000 donors, platelet donors who have been HLA typed. And so we know their HLA and HPA typing. And approximately 3,000, about a quarter of those donors are actually still active in the system. So we've got about 3,000 donors that we could query in our database. If we have a particular HLA type that we're looking for, or if we have HLA antigens that we're trying to avoid, we look for those in our system. We can identify which donors would meet those requirements from an HLA point of view, and then we can contact those donors to bring them in for a specific donation if we don't have products from them that are available on the shelf at the time of the request. This is an example of the platelet donor selection output that we get when we go through that exercise. So this is an example, not related specifically to the case I presented, but just an example of the platelet donor selection output, where we've put in the antigen exclusions that we want and the HLA type that we want, and we'll get a number of matches in our system, which we can then use in our program to identify donors, contact them, and arrange donations to support a patient in need. I mentioned briefly about the option between HLA matching versus antigen avoidance. I think ideally, in an ideal setting, HLA matching would be the way that we would approach things, because you're getting a guarantee that the particular product that you have is going to be well matched and really kind of not susceptible to any antibodies that the donor might have. However, that requires HLA typing of the donors, requires HLA typing of your patient, which we don't always have. It's a bit slower sometimes to get the HLA typing. So in an acute situation, we may get an antibody screen faster when we get the HLA typing of the donor. And it also narrows the pool of eligible donors quite extensively. So those are some of the downsides to it. But there's a higher chance of response if we are able to get an HLA matched donor. The HLA antigen avoidance strategy has the advantages of only needing the HLA antibodies from the recipient. It's much less restrictive. If you're only going to be avoiding antigens and not insisting on a match for a donor, you have a bigger pool of donors to select from, but has the downside of leading to potential sensitization. So in a recipient who's already demonstrated the capacity to form HLA antibodies, if you're not matching for their antigens, you may actually sensitize them further against other HLA antibodies. So there's a bit of a push and pull between the two strategies. And oftentimes we're in situations where we just kind of take what we can get. We're not necessarily being too picky. And if we can get a platelet that's compatible by an avoidance strategy, we'll take it. And if we can't, we'll use the matching strategy. So what happened in our case when we went through these exercises was we identified some donors that were HLA compatible, and we found units and brought them in, and they were transfused to the patient. And you can see here on the left the pre-transfusion and post-transfusion results on 2 episodes of transfusion, and they were fairly unimpressive. The first transfusion resulted in a platelet count that actually decreased slightly, although probably within the margin of error of the analyzer, and the same thing after a second transfusion. And these counts were done very shortly after the transfusion was done, within a 30 to 60 minute window. And present this partly because it's important just to emphasize that moving to an HLA selected strategy doesn't mean that that's the end of the road for our diagnostics and for our monitoring. It's really important to monitor the platelet response, even if we're getting HLA selected platelets. There's a couple of reasons for that. One is that there are limitations to the HLA typing and the HLA testing that we're doing. The HLA typing has only a certain amount of resolution. There are allelic differences between HLA types that may not be appreciated by the testing that we're doing. And there's limitations to the HLA antibody testing that we're doing, where the HLA antibodies that are identified may have cross-reactivity with different groups. And so we may think we're giving a perfectly well-matched or well-suited platelet for a patient, but there may be cross-reactivities between antibodies that we're not appreciating. And so it's not enough to say, well, we've given HLA compatible platelets and that's it. It's important to monitor that response. It's also important to mention that HLA may not play the whole story. And a patient might have HLA antibodies, but they may also have other factors like an enlarged spleen or fevers or decreased vascular integrity that are leading to an increased consumptive state. And so matching with HLA platelets may not actually resolve the issue of platelet refractoriness. And that's important to identify because if we're providing HLA selected platelets but not seeing an increment, we then have to question, well, what's the value of going through the exercise of bringing in donors specifically for that if we're not achieving the increments that we want? And so unfortunately, that was the case for this patient. And so what are our next steps when that occurs? Well, we come back to the HPA system, which you mentioned as of the immune causes for platelet refractoriness is one of is less common than HLA, but still a potential cause of refractoriness. And just as a reminder for the HPA, I think as when I started off in transfusion medicine, I was fairly daunted about the HPA system. It seems so complicated. There's so many different numbers and an older way of describing these antigens and naming them. But really, they're just epitopes that exist on common or much more frequently encountered proteins, the glycoprotein system, so GP2B3A, GP1A, GP1B9. These proteins have differences, variabilities between individuals, and the different epitopes have just been identified and named as the HPA system, so the human platelet antigen system. And much like any other epitopes, we can make antibodies against the epitopes that we don't have. And there are common forms and less common forms of different HPA antigens. And so patients who make an antigen against an HPA, who make antibodies against an HPA antigen, those platelets are also susceptible to immune clearance if they're transfused. So we take a similar approach in if we're not seeing the HLA, the expected responses to a patient who's getting HLA-compatible platelets with HPA testing, where we'll do antibody screening, and at Canadian Blood Services, we do the PAC-LX flow cytometry system, and the monoclonal antibody immobilization of platelet antigens, or MAPA system, for identification of antibodies. And as with the HLA, just knowing that in isolation is not as useful as knowing the HPA type of the platelet. So we'll also do molecular testing to identify what the HPA type of the patient would be. And then the combination of that information can be used to further support a patient if we're not getting the responses with HLA. So in our particular case, who had the HLA antibodies, was quite extensively HLA alloimmunized, but wasn't getting the increments expected with well-matched HLA platelets, we identified actually this patient to have a 1B antibody. So in addition to the HLA antibodies, this patient also had an HPA 1B antibody, which is not as bad as having a 1A antibody, because the 1A is not as, I guess, as commonly, or the 1B is not quite as commonly encountered, but a significant portion of the population, at least in Canada, is a 1A, 1B heterozygote. And so a relatively high proportion of patients would have 1B, at least in the heterozygous state, on their platelets, and those platelets would then be susceptible to clearance. So when we took that information into account and restricted further our donor list to include not just the HLA antigens, but only HPA 1A platelets were selected, the patient went on to have much better increments, and we saw a significant decrease in the number of transfusions that were required to support them. So I will, at this point, shift things back over to Dr. Seftel to carry us through the rest of the presentation.
Thanks, Johnny. I'm going to just see if I can remove the your controls there, but I don't know if, give me a sec. Oh.
If you can't, I'm happy to
Okay.
scroll through for you.
I think it should be okay now. Thank you very much. By the way, Johnny, thank you very much for presenting some of the slides that I think you weren't expecting to present towards the beginning. They were my slides, but you did a better job than I did, so thank you very much. So we're coming to some summary points here, because I think it was important that we had some discussion with the remaining part of today's deep dive with the audience. I just wanted to bring your attention to this summary process and how to recognize and manage patients who are refractory to platelet transfusions. So this is a summary of much of what Dr. Mack has already presented in a single image. And instead of going through this line by line, I wanted to bring your attention that Canadian Blood Services has a web site for professional education. So they have a number of chapters around common transfusion medicine issues directed to healthcare professionals. It's called Canadian Blood Services Professional Education. You can Google it very easily. And there is one specific chapter on this particular issue of management of platelet transfusion and refractoriness. And so this is really straight from that chapter, which talks about recognition and, of course, just good clinical acumen about deciding what constitutes non-immune causes of platelet refractoriness, and then a management algorithm for those where immune refractoriness is considered an important element of the platelet refractoriness. I'll say that both of the cases that were discussed today by Dr. Steyn and by Dr. Mack fit into complex platelet transfusion issues where there's refractoriness and likely both, certainly Dr. Steyn's case, immune and non-immune causes, and in Dr. Mack's case, both HLA and HPA antibody issues. So that is where consultation is required with both laboratory consultation as well as other clinicians to ensure that patients get the best treatment. There's no way, I would imagine, that any one person could manage either of those patients without a lot of teamwork and consultation. Moving to the next slide, if I can. There we go. So just in terms of management, once you've recognized that somebody has HLA antibodies, which is going to be the commonest situation that we will encounter in immune refractoriness, what do you do about it? And Dr. Steyn's case spoke in some detail about a number of immune modulation measures that were taken besides just platelet transfusion. I'll say at the outset that the evidence to support ways to manage immune platelet refractoriness other than providing HLA-selected platelets is not very strong. There are multiple reports of a variety of measures. I think I'll go through it in principle with you now in this one slide, which is, first of all, having HLA-matched or HLA-compatible donors is a good thing. And the more available donors, the better. I know that that goes without saying, but we have, as Johnny was saying, around 3,000 donors that we can regularly call upon for HLA and HPA-compatible platelet needs. And that works reasonably well, although as the ethnicity of patients shifts, as it is in Canada and globally, to those with less typical HLA types, I suspect we will struggle unless our donor pool expands and also reflects the same HLA variability that we are now seeing in patients. Medically speaking, what can you do? Well, you can hopefully remove immunoglobulin, and the classic maneuver that many of us have access to is plasmapheresis. Unfortunately, as you know, it only works short term. It doesn't remove all antibody, and there's often a rebound effect as well. From an experimental point of view, there is a molecule, IDS, which is derived from strep pyogenes, that actually is able to cleave immunoglobulins. There is some work of this around this in the solid organ transplant world, where they have similar HLA antibody issues. But this is not common practice. I would say that this is something to look out for in the world of future clinical studies. Reducing immunoglobulin by suppressing B cells is something that Dr. Steyn referred to. You guys used rituximab for that patient. Anti-CD38 or daratumumab has been used in similar circumstances. I think all within the range of small case series and case reports. And classically, immunoglobulin interference using IVIG is another method that can be used. Again, usually has short-term potential benefits, and the evidence to support it, again, is not very strong. Interestingly, one of the more interesting aspects for intervention would be anti-complement treatment. For example, eculizumab, which of course is most famous for its use in PNH. And that is because the HLA antibodies partner with complement to result in a membrane attack. And interfering with the membrane attack complex via eculizumab is thought to be a potential target in situations of HLA alloimmunization. There is one publication about this from the NIH about 3 years ago, and I am understanding that clinical trial is being expanded. So look out for eculizumab. Not an easy drug to get hold of, but this may be of interest in the future. And then I'm going to just stop and just see maybe whether if anyone can assure that their microphones are off until we're done. Prevention, well, as I mentioned, leukoreduction of cellular blood products is important, and many countries have already moved to universal pre-steroid reduction. I'd be interested to hear what the South African perspective is there. And then purely on an experimental basis, the provision of platelets that can actually be given free of class 1 HLA antigen by the use of citric acid. There is some experimental work on that. Again, not common practice. And then ultimately, and perhaps most hopefully, by the use of induced pluripotent stem cells, the manufacturing of universal platelets that do not bear class 1 HLA antigen in the first place. So that would be nice, but certainly not tangible clinical practice implications now. These are some interesting scientific developments that we may see in the future. So that was a relatively brief, but hopefully still deep dive into the complicated aspects of platelet transfusion. We gave you our Canadian angle on this, and we presented 2 cases that I would love to hear more about in the discussion section as we summarized our approach to diagnosis and management of platelet refractoriness. So we've given ourselves a little bit of time, and I'll then go back to Jacques to hopefully share some questions and answers. Thank you.
Thanks, Matt, Johnny, and Caroline for really interesting first cases and then insight into the challenge. I think as both cases have shown this, and as you've said yourself, it can be very, very challenging. I don't see questions in the chat box yet, but I would like to comment. You mentioned the you having universal leukodepletion. I've looked through the attendees, and I'm not sure if anybody from I see Derek Nelson is here, but so we have in South Africa, we don't have universal leukodepletion, at least for packed red cells and single donor platelets, as far as I understand, is leukoreduced. Maybe Derek or somebody from Sambes can just confirm for me. And then we have pooled platelets that are not leukodepleted or filtered. When we had our case and realized that we will have trouble getting HLA matched platelets in time and regularly enough to manage her safely, we inquired about pooled leukodepleted platelets, which Sambes is busy setting up, but weren't able to provide yet. So we went ahead and gave non-leukodepleted or just standard pooled platelets, obviously risking further alloimmunization. So yeah, I think it would be maybe a question from my side in terms of, because we not infrequently, we've actually got another patient where we've got currently treating also with acute leukemia that's got confirmed platelet immunological platelet refractoriness. And I see from your study from 20 years ago, universal leukodepletion led to a reduction from about 14% to 4% incidence of platelet refractoriness. So it's got a significant impact. In terms of using pooled leukodepleted versus single donor platelets, your thoughts on that? In single donor platelets, yeah, I mean, which is there evidence that one is better than the other, or do you have a preference over sort of for the routine usage of platelets, single donor apheresis platelets versus pooled leukodepleted platelets? Any thoughts on that?
I'm going to just
Dr. Seftel?
Yeah, go ahead, Johnny.
So I would just say, I guess it depends, I guess, on what the how we're defining better. I think there is data in addition to the Canadian Blood Services data, the TRAP study, which is I think even older than the data we had presented from Canada, an American study where it was a randomized trial in hematology patients requiring transfusion support, where they compared the pooled apheresis, leukoreduced, and non-leukoreduced products. And if leukoreduction is being done from a alloimmunization perspective, there's no appreciable difference between the two. So pooled products and versus an apheresis product, if they're leukoreduced, the immunization rates were equivalent. Providing an apheresis platelet, I think, that is not leukoreduced would limit the amount of antigen exposure. So from a perspective of further immunizing a patient, I think the apheresis platelet would make more sense if that's the objective, if it's a non-leukoreduced product. If we're looking at it from the perspective of a patient who's already been sensitized and we're trying to achieve a better increment, which I think comes up not infrequently as a discussion point, whether we should use a pooled versus an apheresis. There really isn't a lot of data to guide that. There's a few case series that have been published suggesting that the use of the pooled platelets results in a better increment in patients who do have platelet refractoriness, which again I think makes some intuitive sense that if you've got a pooled platelet, just by probability, you're more likely to have, you know, some proportion of that pooled product that's going to be HLA compatible, whereas you're putting all of your eggs in one basket, so to speak. If you're using an apheresis platelet, you've only got that one donor's HLA type, and if it's compatible, it's compatible. If it's not, you're just not going to see an increment. So I do think there's some data, but it's quite limited. And you know, whether or not this small dose of platelets that are compatible in a pooled platelet really makes that much of a clinical benefit is, I think, a little bit uncertain. So I'm a bit more nihilistic, I think, in the already immunized patients, whether you choose the apheresis or the pooled. I think either strategy from a prophylactic point of view is not too appealing. If I don't have the option of an HLA selected platelet for supporting a patient, I really avoid using platelets for prophylaxis and would transfuse platelets just in the event of significant bleeding. And I would be fairly nihilistic between the choice of an apheresis or pooled platelet. I don't know if anything else to add to that, Dr. Seftel.
Thanks. And just made me think of another thing that I came across and I wasn't aware of myself, but so in terms of the storage of platelets, room temperature versus cold stored platelets, and I see, if I understand correctly, cold stored platelets may be better or better hemostatic properties in the acute setting, but not for prophylactic transfusions. This issue actually came up in our patient where platelets that were ordered, pooled platelets were ordered around the surgery, around a cesarean section, and it was incorrectly put in the fridge, put in the fridge, not per protocol, but maybe one could have argued that those platelets may have had a better hemostatic action if they were used in the acute setting. Any thoughts on that? Do you offer cold stored platelets in terms of in sort of the setting, or in general, do you offer cold stored platelets at all?
Yeah, so Matt, you want to take that one, or you want to?
I can take it, and then you guys can follow up. So the standard and sort of licensed and regularly manufactured product that is issued to patients is administered at room temperature. And of course, the traditional risk of room temperature platelets has been bacterial contamination, which we hope has been negated by the use of pathogen reduction technology now. When it comes to cold stored platelets or even frozen platelets, that remains, at least in the Canadian context, in the experimental world, we would not be able to routinely issue those at all. You're right that theoretically, Jacques, they may be of some benefit for immediate hemostasis in actively bleeding patients, but not in the setting of our commonest indication for platelet transfusion would be for prophylaxis in thrombocytopenic patients from bone marrow failure, where those platelets that are stored cold would likely be ineffective other than having an immediate and short-term hemostatic effect immediately on infusion. So it's interesting, but I don't know how close we are to being able to provide anything that isn't at room temperature. Maybe a Johnny or a Kush can add to that.
I would just add to that. I think that it's an interesting question. I think it's one that's under investigation. Platelets, I guess, at least in the North American setting, platelets used to be stored in the cold, and it was actually a hematologist oncologist that noted that for the prophylactic use, they weren't seeing the appropriate increments in patients, and so that led to the comparison of room temperature versus cold storage, where much better and more prolonged increments in platelet counts were observed, and so that led to the shift away from cold storage. But really, without considering that platelets are sort of used for two different reasons, we commonly transfuse them to improve the platelet count. But as you allude to, they can also be used to actually support a patient who's actively bleeding, and that I think remains the question mark. There are two Canadian studies that are going on right now, evaluating that, one in the setting of cardiac surgery and another that's in the setting of hematology oncology patients who are bleeding. There was a Norwegian study that was done. It was a pilot trial looking in the cardiac surgery setting, and a recently published study called CRISP-HS out of the US, looking at the trauma situation. None of the studies they're small studies so far, but none of them have found a benefit necessarily to cold stored platelets. But I think the data is still quite immature and still needs to evolve, or needs to mature significantly to have an answer to that question. I guess I'll kind of add to what Matt's already said.
Very insightful. I mean, I think the situation's same here. When we discussed those platelets at where that was stored in the fridge, and we were instructed that if we give them, it's on our own. We take the responsibility for giving the cold stored platelets. At that point, we were willing to do it if she did go into heavy bleeding, but luckily that didn't happen. So
they definitely aren't harmful, and I think the downside is you won't get as much of an increment. But if that's not what you're interested in, you're really sort of interested in that hemostatic effect. I think there's a possibility that it may. I mean, the reason they get cleared more quickly is because the VWF receptors start to cluster in the cold, and that leads then to clearance in the liver. But that VWF clustering, along with some other membrane changes, may actually be more hemostatically active.
Very interesting. Maybe just a few comments from the chat box. Eric Nelson notes that and maybe I can ask a question here as well, just to make sure that I understand things correctly. So in South Africa, single donor platelets are irradiated specifically to prevent sensitization. I always understood that radiation does not really reduce sensitization. It prevents, but maybe I'm wrong. So because if you irradiate a unit, you kill you kill the residual passenger lymphocytes or leukocytes. Does that lead to reduced sensitization? Or in terms of, because I always thought that if you irradiate, they're dead, but the antigens are still there, maybe.
To my knowledge, I think so it is an important point to mention that it is really critical to irradiate any HLA matched platelets, and that's, to my knowledge, primarily driven by the transfusion-associated graft versus host disease concern. I don't know of any data that suggests that there's any less sensitization with irradiation, but with the mechanism of transfusion-associated graft versus host disease, where those lymphocytes in the product can evade the host or the recipient immune system, that's much more likely to occur if you're using an HLA-selected strategy. You're specifically picking a donor because they're a good immune match, which increases the likelihood that those lymphocytes could evade the host response and then start to proliferate and then lead to a TAGVHD. but I'm not aware of any data suggesting that the irradiation actually decreases HLA sensitization.
All right. No, I just, that's how I also had it. And it is about preventing transfusion-associated graft versus host disease. Maybe shifting towards the therapeutic actions. We obviously, as Caroline nicely said, literally through the kitchen sink at this lady, in terms of making sure that she gets good hemostasis during delivery. Unfortunately, we were really hoping to get a normal vaginal delivery, which in the end didn't happen. And that has subsequently, as she said, led to multiple complications. She's had intra-abdominal sepsis, and yeah, actually ended up having a total abdominal hysterectomy eventually, and woundies. And so that's part of the very complicated course that she's followed that's more linked to her immunosuppression and aplastic anemia. But in terms of the management of that, I mean, Matt not clearly said that the data for the steps we took is limited, based on sort of case reports here and there in case series. We also read about bortezomib used off label in this sort of setting. Caroline asked if anybody has tried this or has any experience with using other immunosuppression like bortezomib, or yeah, that was the one that we came across. So any comments from, I'm not sure, from the Canadian team or even on the floor? Yeah.
Others are very welcome to comment, but I would say that, you know, these multiple methods of reducing circulating antibodies by suppressing either B cells or plasma cells, they make sense, they're attractive. And I guess based on the highly sort of variable populations and the relatively uncommon situation, hospital by hospital, proper evidence is sort of weak. Bortezomib is attractive because of its anti-plasma cell effects. It doesn't sound like it's taken off to any great degree, in part because of older studies that suggested that bortezomib itself was associated with thrombocytopenia during the sort of early development of this drug for myeloma, that there may be some effects on megakaryocyte function with it. So I suspect that the enthusiasm to study bortezomib in this kind of HLA alloimmune refractoriness picture was not strong. So yes, there are case reports, and I don't think it's wrong to try it, but there may be some, I guess, alternative interest in other anti-B cell or plasma cell treatments. And I mentioned, and you tried rituximab or daratumumab, or for that matter, the anti-complement drugs like eculizumab, probably have a stronger level of evidence now.
Yeah. Caroline also comments that the role of T cells in alloimmune refractoriness may explain the suboptimal efficacy of B cell depleting therapy. She asked the question if there's any role in T cell depleting therapy. I mean, we plan to give T cell depleting therapy as part of a aplastic anemia treatment, but couldn't prior to delivery because of stock issues. Yeah, any thoughts on that? She does say it seems like a bit of a theoretical stretch, but there's an interplay between T cell and B cell immunity. I mean, it's definitely B cells because we've got antibodies, but I wonder how much T cells play a role.
Well, I would say Caroline's raises a good point, and often T and B cell function are carefully and intimately interplaying. So it wouldn't surprise me. I just was not aware of any sufficient evidence to support that particular intervention of, you know, anti-T cell therapy. So, for example, if you were to use just cyclosporin, ATG is a bit tricky because it's a polyclonal drug, and it, you know, who knows what it targets. cyclosporin's a bit more specific, and I don't know if we've got much evidence for that. I want to just, because I know we're running out of time, and Nicoline Munsami asked another question, Jacques, that I think is quite important. And I don't know if I'm not the best person to answer this, but it is quite an important question. With the question of when to use washed platelets and what benefits that might have. I'm looking at either Akash or Johnny to help answer that better. I just suspect you'll have a more confident answer for Nicoline, but it's an important question.
So I can comment on, like, washed platelets typically used when we want to remove something offending that's in the patient's plasma. So in the context of platelet refractoriness, where we're trying to do antigen avoidance, the washing won't really have a benefit there. So we often use it in the context of allergic reactions where we're concerned about some component in the plasma that we want to wash away. We've seen that when we wash platelets, we do lose 15 to 50% of the platelets as well. So there's a decreased platelet yield post-washing. So it's not ideal. But in the context of refractoriness, not that helpful.
Thanks.
The only thing I would add to that, I guess, is just it does come up for a related but distinct situation, which is the hemolytic or the FNAIT or fetal and neonatal alloimmune thrombocytopenia, where if you're using the mother as a donor, the mother is the one who's giving the fetus or the newborn the actual HPA antibodies in a lot of the situations. And so washing away of the maternal plasma prior to a fetal transfusion of those maternal platelets has a role there. But again, it's because of the antibodies in the mom's plasma that you don't want to be giving to the baby to then worsen the alloimmune thrombocytopenia in the baby. But yeah, I agree with Dr. Gupta's response there otherwise.
See another. Thanks for that, Johnny. I think just another question from Moses. Any studies to determine site of destruction of the platelets in immune platelet refractoriness? So for instance, radiolabeling studies. If it's spleen, would there be a role for radiating the spleen? Sounds quite dramatic, but if one's desperate.
Yeah, I mean, maybe I can answer that, Moses. It's an interesting question, and I don't think there's any evidence that splenectomy is beneficial, but there are, if you think about the situations where we do see HLA alloimmunization, some of them are in situations where patients are hyposplenic anyway. And the typical examples would be in sickle cell disease. And HLA alloimmunization is a problem in sickle cell patients, as is, of course, red cell alloimmunization. And those patients are often functionally hyposplenic. And the same with chronic graft versus host disease, which is another condition of functional hyposplenism, where HLA alloimmunization continues to be an issue. So I mean, I do see your point, Moses, but I think empirically we don't have much evidence that those without spleens do any better.
Thanks, Matt. Apologies for if there's noise in the background. There's a thunderstorm happening as we speak. Yegelin, we're almost at the end of our time. So he thanks you for the interesting talk. He's noted that surgeons often request platelets in an ITB patient to be transfused before splenectomy, an intraoperate unit, and a unit to be kept on standby post-surgery. What are your comments on this approach? Should we keep platelets on standby if surgeons note bleeding? So this is now specifically in the setting of splenectomy for ITP patients. Any comments on that?
I could maybe take this one. I think there's some variability I think that I've observed or that we see with patients with ITP, where not all patients with ITP necessarily demonstrate transfusion refractoriness. So if in a situation where the patient does have some increment with platelet transfusion, I think that would be a reasonable approach. But in 3/4 to 80% of patients with ITP, you really don't get any kind of increment with platelet transfusion. And I would be really reluctant to be transfusing a patient with platelets in that situation prophylactically, especially. I think we often use platelets in someone who's refractory in the event of bleeding, just under the think the motivation that we know that the platelet count might not go up, but whatever transfused platelets, whatever circulating time they have, they can participate in clot formation and help. But it's a bit of a Hail Mary kind of approach. So I think it's reasonable if someone's developed significant bleeding post-operatively, intraoperatively to use a platelet transfusion in that situation, even if you're not getting an increment, but wouldn't aggressively transfuse a patient like that, and would really try and make sure to optimize other factors. You know, we use a lot of tranexamic acid in Canada for support of patients like that without a lot of good evidence behind it, but really just sort of the idea that we'd optimize everything else involved. And you know, once they get the spleen out, then you should sort of see a fairly good increment, hopefully. We do also use quite a bit of IVIG, you know, pre-operatively to optimize the platelet count and sort of help avoid running into situations where the thrombocytopenia is really contributing.
And most often the ITP patients they're usually either responsive to IVIG or steroids, and you can get the platelets up pre-surgery for that. So
yeah, exactly. So focusing more on that kind of before the surgery would be kind of our approach typically.
Yeah. So I think this one could continue discussing at length, but we've reached the end of our time. I think it's been for me a very insightful and valuable road we walked with this patient. And I think I want to just get back to the comment by Matt and also highlighted by Caroline in a talk about the importance of communication in these complex patients. I think, making sure there's a good treatment plan. So there's often multiple teams involved, us, the ops and gynaes, the pediatricians, or whatever the case may be. So I think, communication between teams and people involved with patient is probably the most critical. So thanks everyone I thoroughly enjoyed the session. I see there's a few thanks coming through, and thanks for the Canadian team
We also did.
for joining us. And hope everybody have a wonderful evening and see each other next week.
Thanks so much.
Bye-bye. Bye.
Have a great evening.